Hi, good evening to everyone. Thank you for joining me for this really fascinating discussion that we are going to be having with Professor Christine Stabell Benn. Now, what we have at the moment is a very difficult situation globally where trust in vaccines has largely fallen off. And this is across the board, not just COVID vaccines, but all vaccines. And this is really a problem because, from a public health point of view, there needs to be a way to rebuild this kind of trust. The only way we can do this is by truth and by honesty and by actually looking objectively at the science, asking the hard questions, reflecting on what it means. And that's how we will get to a point where the population starts to trust again after what has happened in the past 4 years. If you don't believe me, a recent study had shown there was a 30% fall in trust in doctors since the beginning of the pandemic, since 2020, all the way to 2024. This is pretty serious and has implications for everyone. And so, without further ado, I'll bring in Professor Stabell. Christine, do you mind? We'll call you Christine. And the first thing I'll ask Christine is I'll ask you to do a quick introduction of yourself to everyone.
Thank you, Philip, and thank you for the invitation to join you at this podcast. My name is Christine Stabell Benn. I'm a professor of global health. My background is that I'm a medical doctor. I worked for 1.5 years as a medical doctor doing my internship, but afterwards, and even before that also, I've been doing research into health interventions and their effect on overall health, primarily in low-income settings in Africa, but also partly in high-income settings like Denmark, my home country.
Excellent, excellent. So, listen, I think just to get the background right, because I did my research and I noticed that as a medical student, you decided to head off to Africa to do epidemiology. What was that about?
So I was interested in ways to reduce the global inequality in health, and particularly the global inequality in child mortality. So I looked at the research done to improve child health, particularly vaccines and micronutrient supplementation studies, to see if I could get an idea for what might be a good weapon to reduce child mortality in low-income settings. And I came across a paper that suggested that giving vitamin A with measles vaccine, to measles patients, could improve the clinical course of measles infection in the patients, and it could also it was observed it could also enhance the antibody response that the patients had after having had measles infection. And the paper ended up suggesting that, it might be a good idea to see if vitamin A supplementation could enhance the antibody response, not only to measles infection, but also to measles vaccine, thereby reducing the risk that the measles vaccine wouldn't work well in children. So I thought that was actually a great suggestion, and I started looking more into the literature and quickly discovered that the WHO, the World Health Organization, was already recommending vitamin A supplementation in low-income settings to reduce vitamin A deficiency. And they actually even recommended to give it together with measles vaccine because of convenience. The idea being that when the healthcare worker was out to give a measles vaccine and was in contact with a child, they might as well provide vitamin A supplements at the same time. But nobody had ever questioned or ask themselves whether these two health interventions, vitamin A supplementation given against vitamin A deficiency on one side and measles vaccine given against measles infection on the other side, whether these two health interventions could actually interact. The assumption was that vitamin A was about vitamin A deficiency, measles vaccine was about measles, and they wouldn't interfere with each other. So I thought that became even more interesting than for me to study whether vitamin A could affect the antibody response to measles vaccine. And indeed, that turned out to be the case. I went to Africa. I was fortunate to find a field station that could host me, and I was fortunate to get funding. And I was fortunate to be able to carry out this randomized trial as a medical student, including almost 500 children who were due to get their measles vaccine and randomized them to get vitamin A or placebo. And I was doing this in Guinea-Bissau, where vitamin A supplementation was still not a policy. So it was not like taking away anything from children who would normally have gotten it. I was able to add vitamin A to some children, and some children would just get placebo and in that way just get the normal treatment. And what came out very clearly was that vitamin A indeed enhanced the antibody response to measles vaccine. And what was even more fascinating was that this was in a sex differential manner. So normally girls would respond with higher antibody titers when they got measles vaccine, higher antibody titers than boys. But when we gave them vitamin A, boys were augmented in their response, so they more responded like girls. So the whole beneficial effect of vitamin A with measles vaccine and on the antibody titers was observed in boys. So to me, this was such a revelation that health interventions, which were assumed to have very specific effects and not interact with each other, could in fact interact with each other, and they could even do that in a very sex differential manner. So that really kickstarted my interest. Well, I had it on beforehand, but it definitely fueled
Yeah,
my
well, this is what I'm thinking. For you as a medical student to do that, that is incredible to be that passionate about global health. What was it before being a medical student that made you so interested in global health?
Well, we spoke briefly about this on beforehand. I think I haven't thought that much about it, but you alerted me to actually, or you made me reflect back and think back of the fact that a few years before I'd been backpacking around the world, and I think that was an eye-opener in terms of global inequality in health. It's a very strong way to see with your own eyes this inequality. So that left an imprint on me, and I think that was what really ignited my interest in looking into how to reduce child mortality.
Yes, fascinating. Now, one of the things, just in case the audience doesn't know this, but Christine actually is one of those who is willing to challenge the narrative that we hear because she's a pure scientist. She just looks at the stuff to try and get answers. So even before COVID, you were taking a stand that was kind of getting the attention in a negative way because you were looking at non-specific effects of vaccines. I would have assumed that everybody was doing it. What was that about?
This is about the fact that vaccines are seen and perceived as interventions against a specific disease. I don't know how that was actually, how it became that way, but you will see if you read, or at least until recently, if you read a textbook about vaccines, they were all about how vaccines would reduce the risk of this particular disease that they were designed against. And then it was about the side effects, the adverse events that could occur, which were typically mild symptoms occurring in connection with the vaccine or in the first days to weeks after vaccination. Everybody was so sure that vaccines just had these two effects, namely to induce specific immunity against the vaccine disease, and that they could, in that process, give these side effects. But that assumption made it what was the background for the fact that vaccines were never investigated for their broader effects. And when you come from my perspective, it's just such a strange omission, but that is the fact. The whole system for developing, testing, and approving vaccines are set up to look only for specific effects and these immediate side effects occurring in connection with vaccination. And then there is this small caveat that, under rare circumstances, vaccines can have serious adverse events that may occur even months after. So this is why phase 3 trials are designed to capture all serious adverse events occurring during the duration of the trials. But they're usually so small that they wouldn't capture very rare events. And that's also why we have put in place a system for notifying authorities if you see something strange occurring in a patient after a vaccination. But basically, the whole framework for developing and testing and approving vaccines pay very little attention to everything else but these specific effects and the immediate symptoms in the first weeks post-vaccination.
I want to ask you something there. This is really important because when we looked at the trials, we'll come to COVID later on, but they were only looking up to 28 days, largely, sometimes up to 40 days after vaccination for issues. But when we think of what happened with the swine flu vaccine and narcolepsy, this was like a year after for a diagnosis, and therefore would have been completely missed if there wasn't really great attention to the detail. And this is some of the, I guess, non-specific or adverse events that can occur with regards to vaccination that gets missed. But you were specifically looking just generally at non-specific effects with vaccines. What did you find?
So maybe if I take you back a step, then I just want to say that for most people, it's really not, it comes as a surprise that none of the currently used vaccines were ever tested for their overall health effects. And again, that was because everybody was so sure they only had these specific effects. And so you might see brochures from UNICEF saying that if you support, with 200 pounds some program, then you'll save this and that many lives. These calculations or these numbers are based on assumptions. They are simply based on the idea that if you know the burden of a given disease and its impact on mortality, and you know the efficacy of the vaccine, then you can calculate behind a desk anywhere in the world what would be the actual mortality impact of that vaccine. So what our group has done, and this was started in Guinea-Bissau before I joined with my studies of vitamin A and measles vaccine, was to provide vaccines to the community. And there, my mentor, Peter Arby, stumbled over the observation that overnight, almost, or over 1 year after introducing measles vaccine in a population where there was no measles vaccine introduced, all-cause mortality dropped by 70% over a year. And that shouldn't happen, because if measles vaccine was just about preventing measles, even if it was 100% efficacious, measles death were only like 10 or 15% of all death at that time. So the introduction of measles vaccine should only have reduced all-cause mortality by 15%. But seeing this large drop in all-cause mortality really spurred the interest in, could vaccines have broader effects on the immune system? And in the case of measles vaccine, to cut a long story short, actually what turned out to be the cases that, and that has been repeated in a number of observational studies and randomized trials, is that measles vaccine trains the immune system in a way that makes it respond more vigorously to a broad range of infections, particularly all kind of respiratory infections, and thereby measles vaccine can reduce mortality much more than just by preventing measles infection. So,
Wow.
yeah.
Yeah, so I was just thinking, so in that respect, does that benefit extend to all vaccines, or was it just the measles vaccines?
So this first observation of measles vaccine led to the hypothesis that vaccines could have what we called non-specific effects. And this is because the effect on overall mortality was simply not explained by the protective specific effects and the adverse events that we already talked about. So these non-specific effects to us are a third category of effects of vaccines that are unrelated to the specific effects, that are unrelated to the mild common symptoms after vaccination, and also to the unrelated to the severe but fortunately rare adverse events like after the swine flu vaccine, the narcolepsy, which was severe but fortunately very rare. Non-specific effects turns out, and I'll come back to your question about which, if it was just measles vaccine, but it turns out that they are related to broader effects on the immune system of the vaccines than currently anticipated. So the vaccines simply affect the immune system in ways that makes it change its response to all kind of different infections afterwards. It simply sets the setting of the immune system, general immune system, differently than before vaccination. if that makes sense.
Mm-hmm.
So this was this third category of effects, non-specific effects of vaccines, we can now document for at least for 10 vaccines that we have studied, and more vaccines are now coming, also are joining this group of vaccines. We have seen now for 10 vaccines, 4 live vaccines, live attenuated vaccines, and 6 non-live vaccines, that they all have these non-specific effects. So the effect on overall health of these vaccines is really very different when you test it in real life from what it should be if the vaccine had only had specific effects.
And so, are always the effects positive, like measles?
So I kind of alerted to that in my first reply, that by dividing the vaccines into 2 groups, and maybe I'll just pause briefly there and explain that we have 2 major categories of vaccines, or at least we had 2 major categories of vaccines before the COVID vaccines entered the field. And these are the live attenuated vaccines that contain the disease organism in a weakened form. So they actually come in and give you a mild, very, very mild version of the disease that you want to vaccinate against, and that create a very broad immune system, immune response that activates all the immune cells that are normally activated in relation to an infection, and thereby these live vaccines usually give long-lasting and sometimes lifelong immunity against the vaccine disease. Then we have a category of vaccines, and these are the non-live vaccines, and they contain the disease organism in a dead version, inactivated dead version, or even just parts of the disease organism or products of the disease organism. And the non-live vaccines don't really stimulate the immune system very much, which is natural because they aren't really a threat in their own right. They cannot cause disease because they're killed or only part of the pathogen, the infectious organism. So this is why these are the vaccines that people will know. They have to go to the doctor several times to get them. You have to get at least, for most of these vaccines, 3 doses of the vaccine to actually get protective immunity. And also they are very usually adjuvated, so they're given together with a helper substance that will activate the immune system to actually create immunity, because in their own right they can't, and by just one injection they can't really create good immunity. So these 2 categories of vaccines are quite different, and they are, both types of vaccines are good at inducing specific immunity. You might need more doses of the non-live vaccines, but in the end, you will end up with having pretty good protective immunity against the vaccine disease. But it turns out when we look at the non-specific effects that they're very different for the 2 groups of vaccines. So the live attenuated vaccines, like measles vaccine, reduce all-cause mortality in our African setting much more than we can explain from protection against the vaccine disease. They simply stimulate the immune system, and we can now show that also in immunological studies, how they do that. They stimulate the immune system so that it responds better and protects the children better from all kinds of diseases after receiving them. But the non-live vaccines, and here comes the real controversy and why I was not unfamiliar with controversy before COVID-19, the non-live vaccines actually hampers the immune system's ability to combat other diseases for a period in the African context. So you might get protection from severe and deadly diseases from the non-live vaccines, but what we have seen again and again now for 6 non-live vaccines is that protection comes at a very high price, and that's particularly for the girls, because girls who receive these vaccines for a period of at least 6 months post-vaccination have an increased risk of dying from all kinds of infections.
This is important here. So when you said that, because this was about in 2016, that you were making this point and you put this forward to the WHO, what kind of response did you get when you were saying that?
Already in 2000, we actually alerted, or by the end of the 1990s, we alert the WHO to the fact that we have these first worrying observations that the diphtheria, tetanus, pertussis vaccine, the non-live vaccine against these 3 serious and potentially deadly diseases, that it is associated with increased mortality. So this is, of course, super worrying to the WHO. So they commission a number of sites to try to test our findings from Guinea-Bissau. What we had seen there was an almost twofold higher mortality after DTP vaccine, which shouldn't, of course, be the case if the vaccine protected against, or when the vaccine protected against deadly diseases. So the WHO commissioned other sites to test our findings, but unfortunately, they didn't really do a good job in sharing the methodology that we had used with these sites. And the sites went on to produce some highly flawed studies that showed incredibly strong benefits of DTP vaccine, up to, one study I think showed a 91% reduction in all-cause mortality associated with DTP vaccine, which is absolutely, incredible. And it also became very clear afterwards, and now also acknowledged by the WHO, that these commission studies had used a flawed methodology, which would in any case produce an extremely biased positive response of any vaccine. And we have published a number of papers where we have gone into details with what are the statistical pitfalls in these analyses and what did they get wrong in these commission studies. Nonetheless, they are actually not retracted or anything. They're still there in the literature. And but I think most people now acknowledge that they were flawed. This was only really acknowledged by the WHO in 2008. So already there was a great delay. And then a further delay before 2013, when WHO then, or their strategic group of experts on immunization, decided to conduct a thorough review of the non-specific effects of two live vaccines, namely measles vaccine that we already talked about, but also the BCG vaccine against tuberculosis on one hand, and then the non-live DTP vaccine that I also talked about. And the review was finished in 2014 and published in the BMJ in the British Medical Journal in 2016. And it was actually pretty clear because it showed that the two live vaccines were associated with an almost 50% reduction in child mortality. But in contrast, the DTP vaccine was associated with a 38% increase in mortality.
Wow. So it raises a question here because, and we're going to come with building the case as we come towards COVID. But even from that time, there appear to be conflicts of interest that, from a public health point of view, because they have a system going, they don't necessarily want to make people anxious about vaccines generally. And so, therefore, they will downplay the negative stories about vaccines. Is that actually the right way to approach the public?
Let me first say, I think I agree with you. It's not a very polite or pleasant interpretation of the motives of public health, because I think we can all shake our heads in disbelief. The public health shouldn't behave like that. But it does seem to be the case that research findings that are inconvenient and are questioning the safety, the general efficacy and safety of vaccines are pushed under the carpet. So yeah, I agree with your interpretation. And no, it's a rhetorical question. It's obviously not the right way in my view to at least to deal with such findings, because public health authorities are put in the world to protect citizens and make sure that they have the best health possible. So you cannot in any way excuse authorities for ignoring or downplaying safety signals in relation to vaccines.
So this perfectly dovetails now into COVID-19. So you've seen all of that, you understand all of these issues. We now come into the 2020. COVID is circulating, lots of death, people are very frightened. The vaccine rollout then starts primarily in early 2021. And I'm going to share my thought here, and I just want to hear your reflection on it. At that time, granted, I was looking at things with autoimmunity, but let's put that aside. But the plan was to give the high risk the vaccine, and that's protecting grandma to save the lives of the older high risk people with comorbidities. And it was very clear from the data who was at high risk. There was no question. It was, we knew it was age, comorbid, it was very, very clear. And so every country could identify their high risk group and give the vaccine to them. One of the strange things that happened was that they then started to go down the age groups to give the vaccines. But before I even go to that, I want to ask you a question from a global health point of view. Let us assume for a second that COVID was as frightening as it was thought or put across as, and lots of people are going to die. How can we explain that we didn't give the vaccine, say, to Africa? What was the thinking there?
I guess it's not surprising in a way, given that we have lived with this enormous inequality in health and access to healthcare for centuries without doing anything about it. I still have the hope that my grandchildren will grow up and they will ask themselves and they will ask us, how could you silently ignore the fact that there was such gross inequality in health, just in a manner similar that we now look back at slavery and say, how could anybody just silently accept a world where slavery existed? So I guess it's there's nothing new under the sun there. There is a way of looking at this from high income country perspective that we are entitled to have a good health, and people in other parts of the world come in second row. And if we have to have any inconvenience or less privileges by sharing them with Africa, then we're basically not interested.
Yes, it's such an important point, and I don't want people to forget that. And there are a lot of people who are arguing about people who didn't take the vaccine and so on and so on. And I'm thinking to myself, those same people didn't recognize that at the initial phases, after the high risk were vaccinated in first world countries, they rather to mandate the vaccine on the low risk cohort rather than to share it
Mhm.
with people who could also have high risk populations across the world. Is absolutely unethical. And I would challenge anybody as to the ethics around that. But let's just assume still that for a second, Africa did get the vaccines. What was the logic, do you think, of vaccinating the low risk cohorts?
Well, we know the arguments that were put forward, but I was all the time arguing that we couldn't we couldn't justify vaccinating the low risk cohorts from the perspective that we didn't know the full story about the vaccines. They were new platforms for delivering vaccines. They had only been tested in a few months, and we had no way of knowing what would be their overall health effect. And of course, coming from my perspective, this was the important question. We had seen that other vaccines could have non-specific effects that could be even more important for overall health than the specific effects, and that could sometimes be negative. So for a healthy young adult with no comorbidities, the risk of severe COVID-19 was literally zero, and therefore any side effect, any negative non-specific effects would have made the equation look really poor for that individual. And this was why I was all the time arguing that there was no justification for vaccinating younger healthy adults, and particularly not children, and definitely not for mandating it.
And so, what kind of, because you would have been one of those voices that they wouldn't have liked saying that because you're high standing in the industry. What kind of pushback did you have, even personally or professionally, when you started to do that?
Well, it was very easy during that time to be tagged as an anti-vax, which is absolutely ridiculous. I've been working on vaccines for decades. I've been promoting particularly those live vaccines. I'm full of scars from the BCG vaccine because I take it ever so often. I'm pretty convinced this is a key to good health because of its immunostimulating effects. But this tag was used so much in the public debate about vaccines, and it became an excuse for dismissing people. It was a tag that you could put on people and then you could stop listening to them. I experienced that quite a lot despite my track record. And I know it was even worse for other people during that period, which was really nonsensical and terribly dangerous to shut down the discussion about vaccine safety in a period of rollout of a new vaccine.
Yeah, this is where it comes back to that public health issue where I think that the powers that be, truthfully, or let me give my take on it, and this is what I genuinely think happened, is that the politicians were sold that this vaccine would stop transmission and therefore kill the pandemic in their country. And so for a politician, it then became a Churchill type event where if your actions stop the pandemic in your country for the next 150 years, people would talk about and I think because the politics then trumped any of the science, the only people who were allowed to speak were people who had something to gain from this. And anybody who questioned it, and even now we have to be careful, would have been put down, misinformation taken off the with the ability to speak. Have you ever seen anything like that?
In globally or personally? Or?
Personally, at any time?
No. So this was clearly, I mean, worse than anything I had experienced on beforehand. I have been in the public debate about also our negative findings, the negative non-specific effects, but I've never been censored like I actually experienced it a couple of times during the pandemic. And even now, the podcasts that I make, they are still coming on YouTube with a little tag on, if you want to have decent information about COVID-19, you should go to the WHO webpage. So they come with these small warnings. So it became clearly worse. And I guess I was smiling by your your Churchill interpretation. It might be the case. It definitely it became as I said, a situation which to me is extremely dangerous because you should never shut down any discussion about vaccine safety.
Yeah. So now I'm going to kind of stretch your mind a little bit here. Now, I know you don't have the data on it, but I want you to just think about something. The Chinese used a whole virus vaccine, but the rest of the Western world primarily used just a spike-based vaccine. When you pull back from that, based on what you have seen, I know it's not quite the same because that would have been more an inactivated rather than a live vaccine. Do you think you would see similar effects between the two?
Between the whole cell or the
The
spike?
whole virus
Yeah,
versus just the spike. This just popped into my head as a
yeah.
question. Hmm.
It's funny you ask because just before the pandemic, I think it was in February, I was on a podcast with a Danish vaccine developer. He's making DNA vaccines, but we were talking about how to develop new vaccines and which platforms to use. And the thing that we both agreed on was that the old ways of administering vaccines, the live smallpox and the live BCG vaccine, which is the tuberculosis of cows that you scratch into the skin, that they have been tremendously efficient and also both seem to come with beneficial non-specific effects. And we talk about how the skin is such a good organ for delivering vaccines, not inside the skin with injections, but just scratching the skin and putting the diseased organism there. So just when the pandemic hit Denmark and we had a first lockdown, I called him and I said, shouldn't we try to do this with COVID virus? Shouldn't we try to scratch it into my skin and see if I could actually develop protective immunity against COVID from that? So basically, this was what we did. He had access to the virus. He could scratch it into my skin, and we could follow my development of antibodies and a cellular immunity. And I have to say, unfortunately, it was super disappointing. Nothing really happened, nothing that we could measure at least. But on the other hand, I can also tell you that it took more than 2 years before I actually got COVID. So there might have been some effect in ways we couldn't measure of this. But this would still be my best bet for a good COVID vaccine, to deliver the live attenuated virus, maybe not directly into the skin, and there might not be sufficient receptors in the skin for this virus, but intranasally. And I know there are phase 3 trials now with intranasal live COVID-19 virus, and that would be my choice of a vaccine, given everything I know about live and non-live vaccines. And coming back to what I think was the gist of your question was the whole pathogen obviously also gives a much broader immunity than just choosing one protein from the pathogen. So I think there are many pros or many things in favor of using whole pathogen rather than just a spike protein, which has turned out to also, be look as if it's problematic to have in a vaccine, and at least to let the cells start becoming factories of this protein, as is the case with the mRNA vaccines.
One of the things that is happening, and it doesn't want to be acknowledged even by public health, is that at the moment we are having another wave of COVID. So the cases are rising again. Well, people aren't necessarily getting very sick, but this is not endemic spread of the virus. This is very unusual in the sense that we shouldn't be having such high circulation, especially in summer months, of the COVID virus. My thought is that, and this is coming back now to, I think we'd mentioned Gert and Gert's thinking, is that what we're seeing here is that the immune system in people who have had the spike focused vaccines is now so hyper focused on the original variant that it is not able to adjust for the Omicron variants, kind of like what could happen with dengue between the different viral strains, where if it gets stuck almost responding to the original strain, it can't respond to the second strain. What would be your thought with that kind of theory?
I should say immediately that this is not my main area of expertise, but I think there are studies that allude to several ways that the COVID vaccines, both epidemiological studies which suggest that you actually get increased susceptibility with increasing number of doses of COVID vaccines, but also immunological studies that gives hints about how this could actually be the case. And I think among many different explanations is this, I guess, what you mention is a variant of the original antigenic sin, that your immune system gets primed towards the first version of the pathogen that it sees in a way that it can't really get out of it again when it meets new versions. It could be related to also the production of IgG4, which has been observed in connection with mRNA vaccines and in increasing production with increasing number of doses. And IgG4 is a tolerant IgG that actually permits infection and is very unusual to find in relation to in any kind of antibody response to any vaccine. So this is something that should invoke interest and also concern that this new vaccine type seems to induce this very permissive antibody. And thirdly, what I'm particularly interested in, coming from the perspective of non-specific effects, is that we have shown immunologically for the non-live vaccines that they are those non-live vaccines and other non-live vaccines that have been associated with negative effects on the immune system in African children. We have seen in immunological studies that they make the innate immune system more lazy. It actually makes it more permissive towards all kind of other pathogens in a period after vaccination. This innate tolerance, as we call it, has also been seen now in several studies, both in adults and in children after mRNA vaccination. So my biggest concern is that the mRNA vaccines work like non-live vaccines, and we see that epidemiologically, we see it also immunologically. They work like non-live vaccines, and the specific protection, which may even be questioned, comes with the price that you are more susceptible towards other pathogens after vaccination, and at least for 6 months. This is what the data suggests so far. And that is really a possibility that we cannot exclude. In fact, there's a lot of data that suggests this may be the case. And this laziness of the innate immune system after a vaccine that primarily gives you immunity towards the original Wuhan strain may actually also be part of the explanation why we are seeing more COVID in this aftermath of the massive vaccination campaigns.
This is pretty significant stuff you're saying there, Christine. I can see why they don't like you talking, because this is important stuff. But I'm thinking, as you were talking, I was reflecting on the children, especially because I remember thinking to myself, and I remember even in the UK when the health minister at the time absolutely said no, there's no need to vaccinate children, because the risk was so tiny, almost zero, with a healthy child. You could argue for a child who has, other conditions. But when you think about these non-specific effects then, and these children are still at a phase where they're developing immunity, that is actually pretty serious in terms of longer term health risks.
I agree, and I wrote a piece already in 2021, in the summer of 21, in BMJ, asking the question whether COVID should be a vaccine disease or a childhood disease. And I was saying, we, as a society, it would be clearly best from all the data we have if children are infected when they are small and they develop natural immunity and they're boosted occasionally, and eventually when they become 80 years old, they might eventually with very high old age become susceptible to get severe COVID, but probably they would be well protected up until immunosenescence really kicks in a very high age. So we would have herd immunity through the children, and the children could have COVID without severe disease. And my concern was that we might actually interfere with that process of developing this good natural immunity that would protect them well into their old ages by giving vaccines early. And so therefore, I thought from a societal perspective, this was really better, but it would also probably be better for the children, and not least taking into account that we still didn't know anything about potential negative effects of the vaccines in the children. And just as I said with the young, healthy adults, etc., the equation was so clear that when you didn't get severe disease from COVID, you couldn't tolerate any negative effects from a vaccine. And what I'm now looking at, and what we recently published in a preprint, is concerning data that suggests that actually the mRNA vaccines in children made them more susceptible to other infections. It made them get at a higher risk of lower respiratory tract infections in general, and this was due to a higher risk, not least, of getting more RSV infections. And RSV, respiratory syncytial virus infections, are much more severe than COVID in childhood. So the trade-off might have been that they got the COVID vaccines. It might even not have protected them very well against COVID, but they became more susceptible through these effects on the innate immune system, among others, to other infections that were much more severe than COVID.
Where are the patient advocates now? Because this is very worrying. That I'm trying to think about at this point, because it seems as though the longer this goes on, the more entrenched the system is becoming. I'm going to show you something that literally half an hour before we came on, I came across, and I just had to reflect on it. So this has just been published in the Lancet, literally 7th of August, you can see here. 7th of August, this has been published. Estimated number of lives saved by COVID vaccination programs in the European region from December 2020 to March 2023 is 1.6 million, they have estimated. Okay? When you look at something like this, how does this fit with regards to the research you have been doing separately?
So we didn't talk about that yet, but we did I'll go a little bit more into details with what we did in children and in adults respectively, because as researchers interested in non-specific effects, we were obviously arguing as loudly as possible when the vaccines were being tested for the studies to include outcomes that were not just COVID-19, but all kind of diseases. Because in principle, any disease in the aftermath of a vaccination could be due to the vaccine. So it's not enough to just look for COVID-19 infections. Studies, phase 3 trials, post-licensure studies should also look at all kind of infections in principle, and on overall mortality and morbidity, because after all, this is what matters to people. They don't want to know if they get less COVID-19, if they die more from other diseases. That's the important, the latter is the important outcome. But the studies didn't, the phase 3 trials we all know very well of the mRNA vaccines and adenovirus vectored vaccines, they didn't test for non-specific effects. They didn't test the vaccines for overall health effects. So we did the best we could do, namely to go back to the phase 3 trials that were published, and also to the reports that were submitted to FDA and to the European health authorities. And we collected in the case of the adult studies all the deaths that occurred in the participants in the phase 3 trials who were randomized to mRNA vaccines or adenovirus vaccines or placebo. And we did an analysis that we published last year in iScience after a long delay, because it was very difficult to get published. But what came out of this analysis was that there was no mortality advantage in the mRNA vaccinated individuals. They didn't die less, in spite of having a lower risk of dying from COVID-19, they didn't die less overall. Whereas when we looked at the adenovirus vectored vaccines, we saw that they were associated with strong reductions in all-cause mortality. And they actually also may resemble more the live vaccines that we have studied. So the adult studies suggest no overall mortality benefit of the COVID vaccines in spite of a reduction in COVID death. And the children's studies that were done in a similar way, and that I just talked about, the ones that we just published as a preprint, they suggest that children got more pneumonias and more RSV infections. In fact, it was a threefold higher, statistically significantly increased risk of these outcomes in the phase 3 trials. So these two papers, these two analyses of overall health effects in adults and in children respectively, suggest that the mRNA vaccines, though they might reduce the risk, at least temporarily, of COVID-19 and of severe COVID-19, might be associated with negative health outcomes that makes the overall health effect negligible or even negative. So to me, a paper that looks only at the effect of COVID-19 vaccine and models its impacts on COVID-19 risk and COVID-19 death, and not all-cause mortality, and comes out with a result on mortality impact, is really not worth the paper it's written on, because it doesn't study the overall health effect. It doesn't study any potential negative effect of COVID-19 vaccines on other health outcomes. And therefore, it's only telling a small fraction of the story.
I remember when I was very worried in 2022, in January 2022, the Euromomo data was published for 2021. And when I looked at the analysis for the age group 15 to 44, there was something like a 9 times increase in mortality compared to, say, 2018.
Mhm.
Now, 2020 was up because there was COVID, but in that age group who should have been low risk, we saw a massive surge in all cause mortality. It didn't say why people were that age group were dying, but they were dying. The excess mortality flag. And I thought at that time they should have stopped to do a detailed analysis of exactly what was happening from an all cause mortality point of view. I really can't explain why. This is where you get worried in the sense that if they are not looking at all cause mortality with regards to prior vaccines, how can we be sure that they were actually as safe as we thought they were?
The big challenge is really to find out what happens here in the aftermath. And of course, there are many reasons why mortality could increase after COVID-19, among them being lockdowns that we know created an immune debt where people were more susceptible afterwards to all kind of infections, really emphasizing that our immune systems aren't meant to be unstimulated by infections. We need to be, and both you and I are probably right now, without even noticing it, dealing with some infectious pathogen. We are all the time, hopefully, in a situation where our immune systems are being stimulated to make them good and on the marks when real dangerous pathogens arrive. So mortality could be high due to lockdowns, due to mental health issues. We know there are many things that were contributing and could partly explain higher mortality. But the challenge is really that we cannot either refute or confirm that vaccines have anything to do with that. And that becomes really difficult when you have rolled out vaccines to so many people at the same time, because we know that there are all kinds of factors associated with vaccine uptake that could influence the results if you compare vaccinated and unvaccinated individuals with regards to their overall mortality. So these observational studies that you can do in after such a massive campaign for vaccines are, subject to all kind of biases that makes them very difficult to interpret. So the real big omission and challenge is that public health authorities didn't test these vaccines while they're being rolled out, because it's getting so difficult after they have been rolled out.
As we come towards the end, Christine, I'm curious as to your thoughts with regards to Africa. I usually use it as a template to show what could have happened if we never had vaccines at all, meaning that we would have still had some deaths, but based on natural immunity, which is extremely robust, the pandemic would be over. From what you are seeing on the ground or with the people you interact with, do they have any problems at the moment in Africa with regards to COVID? It's done.
Yeah.
It's done.
It seems pretty much done, and also there wasn't this high mortality as anticipated. We can show in our population data, at least, that mortality wasn't much higher or actually wasn't higher in the COVID at the height of the COVID pandemic compared with previous years, in spite of lockdowns, in spite of COVID, which was, still a deadly disease in elderly individuals. It's hard to conclude and extrapolate and say we could have done the same in Europe, and we would have achieved the same result, because I think part of the explanation is that the African population was younger, that the helminths that many people have in their intestinal system might actually have had a protective effect. I haven't followed that closely recently, but there were at least these suggestions that immunosuppression from at the Th2 level of your immune system that you get from the parasitic infections might actually have decrease the risk of severe COVID-19. And in addition, there is a general immune system alertness, which is also higher in a highly infectious disease, under high infectious disease pressure. So I'm not sure we can use the case of Africa to argue that it would have gone in the very same way if we had just sort of let it rip in Europe. And I have to say, I was never an advocate of let it rip in Europe either. But I think my main sense was, as I said, I expressed that in that letter I wrote in BMJ in 21, that we should make it a childhood disease and protect the people that had a very high, and you said it so well in the beginning, we knew very well who was at the high risk of severe COVID-19, which we could have protected those, and otherwise let people live their lives and get infected and get over with it. And I would still argue a lot of things point that in the direction of that being a more sensible solution than what was actually carried out. That being said, I have to say I lived in Denmark, and I think we were one of the least restrictive countries. And in that sense, I don't want to criticize my health authorities too much. I actually think they under the circumstances with a lot of unknowns also did a pretty good job. But yeah.
I think, Christine, so this is why I think you are an important voice, because what we have now is that we have a situation where public health is trying to move on and not making any attempts to acknowledge where there were failures. That's one. And I think that the public has clued into that and they don't like that. And that is decimating trust across the board.
I couldn't
But
agree more.
voices like yourself, where you've had a position that you were willing to come out and stand against the narrative, you are a very, very important voice that can help people to realize that there is still trust in the system. There are scientists who are trying to find ways forward, who are genuinely trying to protect, not necessarily influenced by industry, but truly trying to find the best solutions. Really, such an important thing for people to be able to see at this point. So I am taking you now and I am pulling you out from your current thing, and I am, say, putting you in charge of the WHO. Okay? And so, Christine, you are now leading the way. What would you do to try and rebuild the trust that needs to be rebuilt?
I think I would do exactly what you're suggesting, and maybe what was done in South Africa with the reconciliation. I mean, I think we should try to admit what was wrong, and among those are some of the obvious things: the vaccine mandates, the push to vaccinate everybody with an assumption that the effect on transmission would be very strong. And the ignorance of natural immunity, dismissal of the fact that every disease creates some kind of natural immunity. All these major wrong assumptions that were behind the responses of public health authorities need to be admitted and corrected to regain and to deserve public trust. So I would love for an evaluation process with a discussion of all these assumptions underlying the responses, which were right, which were wrong, acknowledging that we were also in a very difficult position with a lot of unknowns. So I don't want to go out and hang anybody or imprison anybody, or I don't want to put a lot of blame on the people. I know personally many of the people leading the Danish response are among my personal friends, and they did all the best they could with the public health in their interest, but they also made mistakes which were obvious, and I think we can forgive them for those mistakes but it would be really helpful. It's much easier to forgive somebody if they admit their mistakes than if they don't admit them. So the starting point would really be for public health authorities to scrutinize themselves, and obviously this is also a good idea for the next pandemic, to be really open and curious about what went well, but also what went wrong.
Beautiful. I couldn't have asked for a better end. So this is really a call to everyone. I know a lot of people are still hurting. A lot of people, certainly in my audience, had experienced the negative effects of vaccine mandates. I know a lot of people in my network who have been harmed and have had no acknowledgement for that from vaccines. And all of that needs to be put in the melting pot so that we can heal and move forward. Because, as you said, I think the main point that you said that I think I've taken away is that there are some very good old style vaccines out there that bring tremendous health benefits, even beyond the disease. And just so that we remember them, I think you said measles, BCG,
The,
um,
the old smallpox vaccine, which is not available anymore, and then the oral polio vaccine that we have also studied, and which is used in Africa.
yeah,
Yes.
so these four big ones, which are live attenuated vaccines, seem to bring the greatest benefit. But we do have to do the research to see what happens for the other types of vaccines and to see whether or not they need to be studied in more detail. I think that's probably the most honest and truthful answer that we have. And it's that kind of answer that I think gives the chance for trust to be rebuilt.
And now I just want to say I praised the Danish health authorities for being among the least restrictive, but there's one place I really blame them, and that is the way they dealt, and you just touch upon those, the people who suffered adverse events after vaccination, because they have been grossly ignored also in Denmark. And it's terrible, and it's detrimental to trust in authorities and in vaccine programs when vaccines were promoted that heavily, but the health authorities are not ready to deal with the fact that some people, fortunately rarely, but some people suffered severe adverse reactions after vaccinations. And clearly we don't know enough about this because we are only finding out along the road. As we touched upon, it's difficult to investigate after the vaccines have been rolled out. But it's very clear to me that some people suffer from complex multi-organ disease that it was initiated by the vaccines, but they're not getting any acknowledgement. They're not getting any help. We're not doing any research to find out what caused their disease, what are the commonalities, what are the biomarkers, in order for us to become better at treating their disease and also predicting in who are susceptible to these serious adverse reactions after vaccination, so we can prevent them in the future. That is a gross omission. And again, to address your question, how do we rebuild trust? This is among the most important things.
Excellent. Wow. Thank you very much, Christine. And thank you, audience, for being with us. Christine, I'll ask you to just hang fire with me for the outro. And until we have another presentation, thank you all for being with us. Have a great evening.